Hello, guys. Hey. Okay, so we are liver and in the flesh, bro. We're in the flesh. I'm back, guys. I'm back. I'm back, guys. Alright, I'm backy. I'm back on, bro. I'm back, bro. I'm back. I just am the backness. Alright, cool. So, we're gonna do some signs and symptoms of the bronchi. Everyone's favorite. Chronic cough. We got a cupful, some dyspnea, some hemoptysis. What's the most common cause of bronchiectasis, and what is the most part of lungs is the condition most commonly affected? I mean, it's the upper, you know how it is. But yeah, it's really just cystic fibrosis. Just want to figure out, we know cystic fibrosis, we know some immunodeficiency, we know some airway obstruction, all right. Some young patients with bronchitis with cystic fibrosis often have what other symptoms? Bronchitis often have what other symptoms? Let's see, symptoms of GI malabsorption. We got some GIs in the building. We got some GIs. That's right. Hey, hey, hey. Some possible causes with frequent cytopenia. I don't know. This is the air obstruction. Okay, cool. Infectious, so some bronchitis. So we got some TB. We got the Mackie. We got the mac and cheese. We got the aspergillosis. We got the TB. We got the mac and aspergillosis. Wow. How what's an exacerbation? So there's worsening of any of those stuff. Cool. And you also have some paralytic chest pain. All right. Physical exam findings. What are you looking at? Lung wheeze and crackles. Crack, crack, crack. Okay. So chest X-ray findings of bronchitis. So you have some dilated tram tracks. You got a tram trackers, and you got the peribronchial cuffing. Peribronchial cuffing, bro. Cuffing. Bronchial wall thickening. Some secretions, but you know how it is. Well, is bronchiectasis a part of restrictive or is it? I think it's obstructive. 1.7, bro. Was in 0.7. Hey, it is what it is. It is what it is. Cystic fibrosis. Let's go with sweat chloride. Sweaty kid, sweaty boy. You're a sweaty boy. All right. So workup, immunodeficiency as the cause of bronchiectasis. What could be the workup? Immunodeficiency. We're looking at quantitative immunoglobulin analysis. IG. Infectious causes of this. We got some sputum. What do we have? Sputum. We got the antibodies. Hey, we got the IgE. We got the IgE. We got the antibodies. We got the IgE. We got the sputum. Especially some like Aspergillus specific antibodies. So we're looking at some management of acute bronchiectasis exacerbation. So we just give them some antibiotics. That's really how it is. Bronchitis patients at risk for frequent exacerbations. So what's the management? Just give them prophylactic antibiotics, bro. Give them the prophies. Give them prophylactic antibiotics. That's how it is. That's how we go. That's how we roll. Okay, so management of like a bronchiectasis. So we're going for the toast. We're going for some antibiotics. We're going to go for bronchial hygiene, lung transplant. Transplant that lung. Yo. Transplant that. Okay. 4 components of bronchial hygiene. Yeah, I don't know. There's hydration, chest, inhale that, and then inhaled mucolytics. Whatever. Causes cystic fibrosis, immunodeficient, airway obstruction, TB, MAC, aspergillosis. Hey, it is what it is, bro. It is what it is. Underlying mechanism for the pneumothorax, everyone's favorite disease, is just air in the pleural space. It's really air in the pleural space, which it sort of compresses the lung. It compresses the lung. Alright, cool. Secondary, so primary, no underlying disease. Secondary, diseases, lots of diseases. What components are the curve 65? C for something, creatine? Oh, it's confusion. U for uremia, R for respiratory rate, B for BUN. Oh, BP, never mind. BP, and then you got age 65. That's important. It's important that we know this. Now, some 4 general categories of causes for pneumothorax. What are we looking at? So we're looking at primary, looking at secondary, some trauma, and we're looking at everyone's favorite wound, the traumatic. So we're looking at iatrogenic, and then the traumatic non-iatrogenic. So it could be stabbings, it could be gunshot. That's a weird way to really picturize it, but hey. So some chief complaints of pneumothorax. So you got some sudden onset, pleuritic chest pain, dyspnea. You have some risk factors. So we have primary spontaneous pneumothorax. So, I don't know. So we're looking at tall, thin, kind of young, smoking, and then we got the Marfan. We got the Martian. So it's the most common cause of secondary spontaneous pneumothorax. What is the most common cause of it? I don't know, bro. I don't know. So looking at CO of PD. CO of the PD. That's kind of weird. Is what it is. CO of PD. Some risk factors for secondary. So we got the COPD. What else we got? So we got some, what is that? Lung cancer. We got the TB. We got some TB. We got some CF. We got some necrotizing. I don't know. Where's the necrotizing ones, bro? Where's the necrotizing ones? I don't give a fuck. Oh, sorry. Excuse my language. Name 3 procedures that can increase the risk of pneumothorax. 3 procedures. Central line. Oh, there's no mention. What the hell? Thoracentis, bronchoscopy, whatever, bro. So, vital signs abnormalities, what are we looking at? So, we're looking at some heart, a lung, and there's a clux. Tachycardia, tachypnea. Both. Alright, so physical exam findings of pneumothorax, we're looking at some decreased chest rise. We're looking at some resonance to percussion. Hey. Decreased breath sounds, hey? So distant breath sounds, there's increased risk on percussion. Percussion. Do you hear that? You can't hear that. Decreased chest rise. You can't even rise that chest. Okay. Chest x-ray findings on pneumothorax will be collapsed lung. White visceral pleural line, absence of lung marking beyond that line. I don't know how that's really white visceral pleural line. I don't know, bro. Absence of lung marking beyond that line. Wow. Management of a pneumothorax, and you just do some supplemental oxygen. Needle aspiration, that makes the most sense. And stop the smoking, bro. And then name 2 procedures. Pneumothorax. Needle aspiration, tube thoracostomy. Hey, it is what it is. What is that underlying mechanism for tension pneumothorax? It's air in the fluid that enters during inspiration but cannot exit. Well, we're not going to remember that. Well, complication of tension pneumothorax can lead to hypotension. We got some tachycardia. We got the hypoxemia. What complication? Shock? That's literally what shock is. Alright, whatever. Tension pneumothorax, some physical exam findings. Cold, clammy pulse. Trachea. Oh, deviation of that. And JVD. Everyone loves JVD. In which direction trachea deviation pneumothorax? Depends, right? Away from the side of the pneumothorax. Hey, it is what it is, bro. Away from the side of the pneumothorax, bro. Come on. Of let's say let's say you want to manage that tension pneumo, bro. I love a tension pneumo. So just medium needle key conversion followed by a tube thoracostomy. You're not waiting for the chest X-ray. Just go for it. Just go for it. Okay, cool. So what clinical syndrome is characterized by a diffuse inflammatory lung injury? Syndrome is characterized by a diffuse inflammatory lung injury. There's ARDS. AR of DS. Wow. Wowzer. What mechanism causes this pulmonary edema? So we have alveolar capillary permeability. Lots of that. So that causes pulmonary edema. All right, all right. Now, what ventilation perfusion defect is seen in ARDS? Mismatch, right? All right, that's kind of cool. The Q is kind of small v, but big Q. Biggie. The biggie. I'm talking about a biggie, bro. I'm talking about biggie here. The Curve 65 scoring system for CAP, how do you do the following scores? Direct inpatient over outpatient. So we're looking at 0 as an outpatient, 1 to 2 as something of an admission, 3 is definite admission, 4, 5 is ICU. IC of the U. IC to U. I say, what effect does ARDS have on like lung compliance? There's decreasing. Whoa, no compliance. 2 changes in the lungs with ARDS that lead to pulmonary hypertension. 2 changes. What is that? What is that? Hypoxic vasoconstriction. That's D of AR. I don't know, bro. 15? Where's that mentioned? It's not mentioned anywhere. So trally is ARDS caused by transfusion of what? Plasma containing blood products. FFP, bros. FFPs. Okay, that's kind of cool. That's kind of cool, bro. Hey, it is what it is. Risk factor, social ARDS. I don't know. Alcohol. They didn't mention this. We gotta know alcohol, boy. Vital sign abnormality. What are we looking at? Hypoxemia. Blue face, yo. Blue face. Mild severe, moderate severe. Okay. PA. So how do you determine severity? PA over FiO2. Patient to be fit. So less than 300, less than 200, less than 100. Yeah, this makes sense. This makes sense. We love it. We love it. Now, physical exam findings of ARDS. We have some everyone's favorite cyano. So we got the lung crackles. ABG finding and lab values. So we're looking at some hypoxemia. Okay, so what is that? PO2 of less than 72. Whoa. I don't know how you're gonna remember that. 1680. It's anywhere between that, bro. Between 1680, yo, dude. Come on, bro. Come on, let's go. Big A, small A, bro. It is what it is. It is. What is the workup for ARDS? Hey, go for that PO2. Go for that SPO2. Go for the ABGs. Go for the chest X-ray. Chest X-ray findings in like an ARDS patient. Looking at some bilateral, some kind of alveolar infiltrates. It is what it is. It is what it is. Vent settings managed in ARDS. Tidal volume, peeps, and FiO2. Let's go. What happens to the TV? I was going to my TV. Low tidal volume. Whoa. Peep is maximized. Whoa. Let me manage in ARDS. So go for tidal volume less. Should be more. FiO2 should be below 60. Whoa. Below 60. Crappy do, yo. FiO2 should be less. That's kind of weird, bro. We don't want to do that. That's so weird. So freaking weird, bro. Now, what tidal volume should be given in ARDS? And why? I don't know. It's kind of low. So super low, bro. Looking at a 6M. 6 ml per kg. Now, low tidal volumes minimize barotrauma and risk pneumothorax. We don't want pneumothorax happening from high airway pressures. Okay, that kind of makes sense. Why is PEEP used in ARDS? Okay, so it's 88.95. 88.95. Okay. What should FiO2 be tried to do in ARDS, and why? What should FiO2 be tried to do? I don't know. Less than 60. We didn't just talk about this. What's the definition of paranemonic effusion? So it's just pleural effusion adjacent to bacterial pneumonia. That's what it is, really. 2 types of paranemonic. So we're looking at uncomplicated, complicated. Okay. Paranemonic was exu, bro. It's exudative. It's an exit sign. We got it. Because basically you have like, it's not just WBCs. You also have like some pH low. You also have like hypoglycemia features. You also have, I believe, something else. Bacterial invasion. That's really what it is. Some management of non-therapeutic community-acquired pneumonia. If you're getting some isolate those. Isolate those guys, bro. Isolate them, bro. With droplet precautions. Two types of primary. I'll just need a pulmonary fluid collections. What are we looking at? With that contain locklines. We're looking at a complicated paradigmatic infusion. Also some empyema. Expert, bro. Expert that. Expert. Empyema. Gooey. Empanada. Oh, that's kind of weird. Alright. So definition of empyema. What is it? Frank pus in the pleural space. Frank pus in the pleural space? Okay, that's kind of weird. I'm going to be honest. It's kind of weird. Chief complaint bacterial pneumonia with parapneumonic effusion or empyema. Prolonged fever, and you also have pleuritic chest pain. Pleuritic chest pain. Prolonged fever and pleuritic chest pain. That's all I want. Timing of onset for uncomplicated versus complicated parapneumonic effusion and empyemas. Kind of complicated. Complicated. Present later. Of course it present later. What the hell? Aspiration and also immunocompromised. Okay. Be different from lung consolidation. Well, you also have like. Okay, so there's also decreased breath sounds, and also a decreased tactile firmness. That's kind of weird. Wow, bro. That's kind of wowzer. So parapneumonic effusion empyema. There's the increased WBCs. Okay. Why might additional imaging be obtained in parapneumonic effusion? To value for loculations. What three imaging options can be used to value for loculations? We're looking at a lateral decubitus, we're looking at chest ultrasound, and we're looking at just the chest CT with contrast. The contrast guy, lateral, chest, where's the ultrasound? Where's the boogies, yo? Where's the ultrasound? Wait, so that's kind of weird. What did I just read? Okay, so that's what you gotta do. So you do lateral decubitus, ultrasound, and then one with contrast. I love the contrast. What is the significance of free-flowing pleural fluid and lateral decubitus? I don't know. It's kind of suggests no loculations, bro. Free-flowing means there's no like gap. There's no like holes. What imaging modalities is to guide site choice for thorax synthesis? Obviously USG. What the hell? What is the imaging modality of choice for diagnosis of loculated parapneumonic effusion or empyema? Imaging modality. Looking at the favorite, the CT contrast, bro. All right, let's go. Three conditions that are associated with pulmonary. I think we talked about empyema. We talked about complicated parapneumonic effusion. What's the other one? TB. Everyone's favorite. TB. Actually, you know what? I got some things wrong here. It's associated with it, but not exactly. Hemo, chylo, TB. Hemo, thorax, chylothorax, TB. Hey, it is what it is. Indications for if you have like this one, large effusion, like more than 20. Whoa, loculated effusion. Whoa, that's kind of. If you have loculated effusion, that's kind of whoa, dude. Kind of whoa. Diagnostic thoracosynthesis is indicated for what size parapneumonic effusion? More than 25 mm. Dude, 7 pleural fluid studies for effusion. So we're talking about cell count. Well, they didn't mention it. That's kind of stupid. You should mention it. Passing culture, protein, LDH, glucose, PHA. Should be culture for what's 3 types of organisms? I think we know TB's one of them. What's the other ones? It could be, I don't know. Aerobic, anaerobic, mycobacterial. Well, that's just boring, plain boring. What's 3 components of your favorite lights criteria? 3 components? I don't know. There's everyone favorite. I mean, we know if it's like if it meets more than one of those light criteria, that's when you know. Okay, it's kind of exudated. 1 or more. Any one is like okay, exudated. Other than that, transudated. Pleural fluid analysis on complicated parapneumonic effusion. Everyone's favorite. Everyone's favorite. It is everyone's favorite. I will be honest. I do like it. Parapneumonic effusion. So what are we looking at? There's an increase in WBCs. We love our WBCs with the neutrophil predominance. We love the negative gram stainies. We got normal pH. We got all that stuff. What is considered normal for pleural? pH should be normal. Glucose should be normal. More than 60. Well, they don't have that mentioned anywhere. So, freak that. Pleural fluid analysis complicated. You'll have low pH, less than 7.2, glucose less than 60. That's really how it is, and you have a gram stain. You got the Grammys. You got the Grammys, bro. You got a 7.2. You got the chocolate. You got the low chocolate. You got a Grammys. You got the pleural fluid studies of empyema. Come on, empyema, pus. That's really what it is. Management obviously will do thoracentesis. You will have some fluid. Oh no, never mind. Actually, don't even listen to me. Just go over serial X-rays and antibiotics. Really, what it is? Antibiotics, serial X-rays. Alright, cool. Complicated. Now you go for like your favorite antibiotics with antibiotic coverage. Obviously, you'll have some tooth thoracostomy. You got your surgery. Hey, you got surgery. You do have it. Okay, I'm not saying don't do it. You do have it. When should anaerobic coverage be given with antibiotics for complicated parapneumonic effusion? So aspiration is kind of likely, and pleural fluid has putrid odor. When should aspiration be aspiration? And pleural fluid has putrid odor. That's really what it is. It really do be like that. And finally, small to medium parapneumonic effusions. What are we looking at? Blunting of costophrenic, cardiophrenic angles. That's really it. That's really what it is. Stands out. Okay. Chest X-ray, large parapneumonic effusions. And there is meniscus or white outward mediastinal shift away from affected side. And okay, so what types of bacteria should empirical cap therapy cover? Typical, atypical. Okay, so you got typical and you have atypical. Okay. It's not really good, but imaging for pulmonary embolism. So you got CTA, VQ, echo. I thought we did this. What? I thought we did this super well. I mean, it's never good until you know it. Now I've realized that what organism is the number one cause of CAP? What is the number one organism? What is the number one cause for CAP? I don't know, bro. Strep pneumo. Everyone's favorite strep pneumo. Strep pneumonia. Come on, bro. Come on, you ain't messing with that. Number one cause of CAP. I don't know. Strep pneumo, apparently. Describe the administration method for antibiotics in community-acquired pneumonia. Outpatient is PO, and inpatient IV. Makes sense, and what the hell? An IV. Be used for treatment of CP without MDR risk factors. There's zithromycin, there's resistance to clarithromycin. Well, that's kind of stupid. Without MDR risk factors, zithromycin and clarithromycin. Risk factors: MDR, strep pneumo, and CAP. There's antibiotics. There's comorbidities, local resistance. Okay, whatever. Outpatient treatment options with MDR, strep pneumo risk factors. PON. Macrolide or doxycycline plus anti-pneumococcal beta-lactam. We're getting weird a little bit. What the hell are you guys talking about? Beta. Respiratory fluoroquine. Where's the... That's just a pneumo driver. What is that? This is a weird one. Is it even a bird? That's a bird. That is a bird. That's a bird, bro. That's a bird. Whoa. Beta-lactams, and you got your favorite fluoroquinoline. What are two respiratory fluoroquinoline? So we got... Yeah, this is important. Levomoxy. Levitator mock. Yeah. Levitator mock, bro. Yeah, that's important. Levofloxacin and moxifloxacin. That's actually kind of important. So what anti-pneumococcal beta-lactam antibiotic regimen can be used along with macrolide or doxycycline to treat the CAP with MDR, strep pneumo risk factors? So we have amoxicillin. We have clavulanate. Okay, we got that. Okay. And you have inpatient treatment. What are we looking at? We're looking at macrolides again. We're looking at doxies. We're looking at some respiratory fluoroquinolines. And the inpatient. So we got the levofloxacin and all that stuff. Okay. Then we got name 5 IV anti-pneumococcal beta-lactam that can be used for inpatient treatment of CAP without MDR factors. So we have ampicillin. We got sulbactam. We got ceftriaxone. And we got our favorite. We got our favorite ones, bro. Cefotaxime, well, whatever. We got our favorites. That's all it is. That's all it is, bro. We got ertapenem, merging. Ertapenem, really. That's where he got it. That's where they got it. This is how they are. This is how they are, bro. Okay, ertapenem is kind of weird to remember. Indications: empiric pseudomonas coverage in a CAP. Let's say you have a cystic. Let's say you got some pseudomonas. That's not even mentioned. Whatever. Bronchiectasis. Do you got some COPD? Do you have COPD? No, you don't. Do you have gram-negative bacilli on sputum? No, you don't. You don't have that much. The bacilli on sputum. Okay. Money with risk factors for Pseudomonas are double coverage IV, anti-pseudomonal. You got beta-lactam. You got fluoroquinoline. Interesting. Okay. And then that's it. Okay, so name 5 IV anti-pseudomonal beta-lactam antibiotics. We got pipetazo. You got ceftazidime. You got cefepime. Meropenem. I mean, that's kind of weird. Deemed. Pipetazo. And then ceftazidime, cefepime, meropenem, imipenem. Okay. Imipenem, meropenem, cefepime, ceftazidime, pipetazo. And then name 2 IV anti-pseudomonal fluoroquinoline. So you got Levo and you got Cipro. Levo and Cipro. Okay. Empiric MRSA coverage for CAP indications are empiric MRSA coverage for CAP. So you got gram-positive cocci on sputum and recent influenza. Yeah, this is going to be tricky. Coverage for CAP indications. Gram-positive cocci. This font is so stupid. Yeah, this is like kind of stupid. Like, why are we going through this? This font is stupid. Like, yeah. I don't know how. CAP with MRSA risk factors. So you had Vanco or linezolid. Yeah, I mean, you do kind of have the Vanco, linezolid. It can be used to guide empiric treatment of HAP and VAP in specific hospitals. Hospital antibiograms. Nice. Hospital antibiograms. Yeah, super cool. Option 3, option without that, what are you going to give? Pipetazo. Do you have that? Where is that mentioned? This is so piping. Okay. What? Prime? I don't know. Cefepime, prime, levofloxacin, Levo, and then leave. Whatever, bro. This is so weird. Yeah, this is a weird one. How are you going to remember this one? This is, yeah. Yeah, that is a weird one. Leave me a clip. Okay, levofloxacin. With the risk factors, there's vancomycin, linezolid. Yeah, this one was a little weird. I don't like it that much. This is, yeah, I didn't think it would be this good. It's still kind of bad, in my opinion, but, you know, double pseudomonas and MRSA. IV antibody, did it mention 90? Anywhere 90? Where's 90? Nowhere, dude. Alright. Ventilator support. Septic shock. Alright, that's how it is. Inpatient treatment is aspiration PNA. IV ampicillin, sulbactam for anaerobes. Okay, IV ampicillin, sulbactam for anaerobes. Okay. Treatment for primary influenza is neuraminidase inhibitors and hospitalization. That would be weird. So we're looking at oseltamivir. Tammy. It is, yeah, that's a weird one. I don't know how I'm gonna do this. Treatment. Lesional pneumonia respiratory. Fluoroquinoline, macrolide, and everyone's favorite doxycycline. Okay. Treatment of pulmonary blastomycosis is itraconazole. Okay. How should empiric antibody therapy be narrowed in pneumonia? Based on diagnostic test results and clinical improvement. Test results and clinical improvement. Yeah, that is a weird one. How are we going to do that? What indicates a patient is ready to transition from IV to PO antibiotics for pneumonia? Clinical improvement, usually within 48 to 72 hours. What is the time frame for transitioning from IV to PO antibiotics for pneumonia? So usually within 40 to 72 hours of clinical improvement. Okay. 40 to 72 hours of clinical improvement. Okay. Antibiotic treatment duration, 5 days. And HAP, VAP is for 7 days. Okay, so from 5 days to hospital course, like 7 days. Cap to HAP. Alright, whatever, dude. When considering stopping antibiotics for pneumonia, what level it can be monitored? So we're looking at procalcitonin. It really be like that. Pros. We're going for the pros, bro. The pros. We're going for the pros. For HIV 1, 2 with regards to the following: prevalence, virulence, location. HIV 1 virulence is more common. I don't know about that, bro. I don't know about that. I don't know. Actually, yeah, we do know HIV 1 is more prevalent. Yeah, we kind of do know that. Mode of transmission of HIV. So it's usually sexual, needle, child stick. Bearing, drooling, open wound, pierced by arrow, pregnant. What else we got? Bloody milk, secretions for... Okay. Like, okay, come on. There's blood, there's semen, rectal fluids, vaginal fluids, breast milk. Yes, breast milk also. But not tears. It's weird. They say drooling. What? Open wound? What is drooling? They just said it's not spread by sweat, feces, urine, saliva, tears, but semen for some reason can. Blood, some reason can. Rectal fluid, yeah, some reason can. But not urine. Fluids, breast milk. Whoa. Yeah, how does HIV cause immunosuppression? Destroys CD4 T cells. Yeah, it destroys CD4 T cells. The CD4 is like locked up, bro. What is the time frame in HIV for decline in CD4 count and rise in viral RNA as HIV disseminates and seeds lymphoid organs? Initial 3 to 4 weeks. Okay. Blue is the CD4 count, which is super weird. Orange is the viral. That's kind of weird. It goes like boom, boom, and this is like the viral RNA. Kind of cool. Obviously, the more viral RNA, the less will be CD4 count. That should make sense. Alright, so you do have that. Now, how long after initial infection are HIV antibodies first detectable? Antigens and what happens to viral RNA? So looking at 3 to 4 weeks, that doesn't look anything like that. 15 to 20 days, whatever that's supposed to mean. P24 antigen. 24 days, bro. 24 days. In between. We're talking about in between. Okay? We didn't give two fricks. Antibodies like that. That's just the antigen. And decreasing. Yeah, it keeps decreasing. Alright, so now when does CD4 count peak after like the initial infection? When? So I think we're talking about CD4 is like 6 months. Viral is like less than 3 weeks. Wow. That's a peak, bro. That's some peaks. You got some peaks. Alright, that is a weird one. So, how long after the initial HIV infection does AIDS develop? Everyone's favorite. The AIDS. How long after initial HIV infection? It's like 8 to 10 years. Whoa. It's about years, bro. It takes years. HIV is considered to be AIDS at what CD4 count? As in 200, really? Oh, yeah. Sure. Two defining criteria for AIDS. So you have to have CD4 less than 200 and an AIDS defining illness. An illness, boy. You need less than 200 and AIDS defining illness. That's really what it is. Chief complaints. So you got some early symptomatic HIV infection. There's 8. There could be so many. Seroconversion, whatever that's supposed to mean. Fever, nodular growths, lymphadenopathy, red mouth, sore throat, generalized macular rash, painful lip ring, okay, hole seared, okay, thin arms, yeah, you'll have that, brown puddle, GI stuff, headache, okay, it's a lot to take in if you've never taken it. Okay, so let's move on. How long after the exposure do acute HIV symptoms usually present? And acute HIV symptoms coincide with what process? Everyone's favorite. So, how long after exposure? It's about 2 to 4 weeks. They don't mention it. Seroconversion, whatever. Really, that can be seen in early HIV infections. We're looking at some painful, shallow white bases. Painful is kind of shallow. It's kind of painful. Sharply demarcated. It's an erythematous border. Yeah, it's kind of weird. I don't like it either. Most common chief complaint, acute versus chronic. So, nice. All right. They're very happy people. Happy guys. Chief complaint, chronic symptomatic. So we're looking at lymphadenopathy and some infections. Lymphs and the infections. So highest rate of HIV worldwide, Africa. Come on, we know that. Most common for the heterosexual transmission. Is there men who have sex with men? They're talking about us. What's up? Then risk factors. So, of course, multiple sexual partners, MSM, not using condoms, Other STIs, IV drug use, groin, transmission, IV with mortar and pestle. And you got syringe arrows. Nice. Now drooling, physical exam, fine acute, vital signs of fever. You have lymphodenopathy, oral ulcers, and you got maculopapular rash. Okay. Maculopapular rash, oral ulcers. (15 to 16, 16 to 65). What is this? Oh, okay, never mind. High risk patients. We have that right there. IVD. We got the IVs. We got the multiple. We got the IVDs. From childbirth. Obviously, pregnant people. Screening tests for HIV. P24. But where's 24 mentioned? We do have 24 mentioned there. And also HIV 1 and 2 antibodies. And in window period, first 3 to 4 weeks. Alright. I'm sorry I made that noise. I didn't mean that. I didn't mean to. If HIV antibody test is negative, what other lab tests can be done to rule out? We talk about what are you talking? P24 we talked about. The HIV antibody is fine, we talked about. RT-PCR, we had to go with the reverso transcriptome. Sensitive lab test for detecting. It has to be viral RNA. Viral. And then like 10 to 15 days, okay. Crescent moon, I don't know why. Is crescent moon supposed to indicate 10-15? I must be bad at this stuff. Because, yeah, I don't remember. 4th generation, HIV 1, HIV 2, RT-PCR. Yeah, I don't remember what we did. Yeah, 6th grade, I barely remember how I even passed. Yeah, I don't remember. I think I remember a little bit. You know, a little bit. I remember calling my dad and something like that. But yeah, that was mostly it. Okay, 4th generation, RT-PCR. When is HIV the most contagious? It's kind of early due to high viral load. Yeah, it really do be like that. What serological tests help to distinguish mononucleosis from HIV? It's basically EBV, CMV. That's really what it is. There's STI testing. Oh, for fuck's sake, what are we gonna remember this for? Hippos. You're gonna remember hippos, dude. TBs. What else are you gonna remember? Pills, HPV. Beware the resistance. Underlined. What's that? Baseline. So we go CBC, blood glucose, lipids. CBC, blood glucose, lipids, creatinine. Okay, and then crushed viral spellbook. Okay, all seeing eye. Helper T-square. Okay, measure the baseline CD4 count. All HIV positive patients. Monitor regularly during therapy. Okay. I mean, that's a lot. It's a lot to take in. It's okay. Antiretroviral therapy and HIV should include which drug classes? So looking at everyone's favorite nucleoside, we got some other classes, the tides and the sides. The tides and the sides, bro. It really do be like that. The target viral load with HIV therapy. So obviously, it's going to be undetectable. How often should viral load be monitored? But they're saying 4 to 8 weeks. We don't know that. We don't know. 6 to 8 months. What is the protocol drugs duration for post-exposure prophylaxis with HIV? How soon should it be started? As soon as possible. Whenever you want. ASAP. But it's saying 72 hours. What the hell? Let's continue. Source patient is HIV negative. 3 drugs, 4 weeks, ASAP, HIV negative. HIV negative. Describe a typical PrEP regimen for HIV. 2 drug regimens, tenofovir and emtricitabine. Difference between chronic and AIDS. Chronic is like I think more than 200. AIDS has to be less than 200. It has to. Otherwise, it's not AIDS. It's not AIDS. Yeah. So advanced HIV. CD4 less than 50. Oh, whoa. Okay. What is an AIDS-defining illness? Opportunistic infections. We got some malignancies. We got everyone's favorite HIV directly. All right, cool. That's kind of cool. What is a wasting syndrome? It's basically that with like 10% body weight loss. Nice. 10% wasted 10. Hey, it's a cool number. Common constitution chief complaints of AIDS. We're looking at some weight. Now we're looking at everyone's favorite lymphodenopathy. Bro, come on. Weight loss, fever, What are we looking at? Some malignancies. Let's look at some lymphomas, everyone's favorite. Cannot be so water infection. EBV. I love that. CBC findings of AIDS. Cytopenias, pancytopenias, that's mostly it. Conditions seen with CD4 less than 200. Oral. Okay, this is kind of weird. Okay, where's that? So we're looking at in EBV, we're looking at some tongue, we're looking at the Canada, we're looking at PJP, pneumocystis gyrovecii, we're looking at some cavitary TB, we're looking at some viruses, we're looking at some dry cough tree, looking at some everyone's favorite recurrent bacterial antigen, we're looking at bacterial pneumonia, looking at some African warrior kidney, whatever, dude. Canadian vulvovaginal candidiasis, bacterial vaginosis. So basically HPV. Looking at some dementia. We're looking at some multifocal leukoencephalopathy. We're looking at some Caesar, PML with ataxia. Yo, he's kind of ataxic. What is this? Kaposi sarcoma. Earth beast covered in purple posies. Kaposi. What is this? A snail. A molluscum. Nice. Very nice. Alright. Cool. I just seen with CD4 less than 100. Wait, so what was that before? So less than 200, really? Sorry, are they all on like one? So on the ground it's 200. Okay. And where's CD400? Is it like below? I don't get it. Okay, so now I get it. So anything on this one is 200. Anything here is 100. Anything here is 50. Oh, that is so cool. What a way to talk about it. Nice. This is amazing that they've done it like this. This is how it should be. So we're looking at, what are we looking at? We're looking at some painful ocular symptoms. Looking at some watery discharge, HSV keratitis, carrots, ocular dwarf. Okay, dwarf. Then we got some Canadian goblin, so Canada esophagitis, herpes. Oh well, yeah, everyone loves that. What is this? Cryptosporidiosis. We got some microsporidiosis. Okay. Cracked kidney can cause AIDS, cholangiopathy. Looking at some genital herpes. What is this? Toxoplasmic encephalitis. Okay, cryptococcal meningoencephalitis. Okay. And then we're looking at bacillary. I don't know how this is bacillary. Really? And I can kind of remember this. I don't remember this one. Toxoplasma. Oh, it's Toxocat. It's a cat? That's the weirdest cat looking ever. That's angiomatosis. Wow, they've done this very, very efficiently. Very, very cool. They've done this. Really, they have really done it well. Yeah, they've done it extremely well. This is a very cool image. Okay, conditions seen with everyone's favorite CD4 less than 50. So, what are we looking at? We're looking at CMV retinitis. Yeah, I don't know how. Megatroll gripping neck. I mean, CMV esophagitis is the next one. Cryptosporidiosis. Some of it goes down 50. We got high fever, disseminated multi-organ. We got some melena, hematochezia. Okay. What is that for? CMV colitis, crab helmet, with Epstein's brew. We got CNS lymphoma. We have CMV encephalitis. So delirium, confusion, and focal neurodeficits. Okay, so we have AIDS. Soap. Okay, that is a weird one. That will be a weird one. Okay, so what conditions presents in AIDS as white plasma that cannot be scraped off? What conditions present in AIDS as scraped off? So we're looking at oral hairy leukoplakia, looking candidiasis. That's really it. What more did you ask for? Some oral hairy leukoplakia in like AIDS. So looking at some chief complaints, like usually it could be asymptomatic. It's usually like less than 200, kind of EBV related. It's kind of white patchy. Location, lateral tongue. I don't know what. Lateral? Yeah, and no one's remembering that. Okay, lateral tongue on the lateral. Really? That's just, yeah, lateral. Oh, tongue lateral. Nice. Okay. Forgive me, I am a little weird. I'm a little weird, is what I'm going to say. Hemoglobin, OHL, everyone's favorite. Oropharyngeal candidiasis are common in AIDS, but usually asymptomatic. No. Can plates be scraped off? No. Oropharyngeal candidiasis in AIDS. Is less than 200. Description of leaving thick white plaques. Tongue or cheeks. Can lesions be scraped off? Yes. Treatment is clotrimazole or myconazole lozenges, nystatin, and swallow. Treatment for severe recurrent is fluconazole. Come on, where's my flus? Where's my fluconies? That's a pine cone? Yo, give them lozenges, bro. Give them lozenges. Where's the pine cones? Where's the pineys? Oh yeah, it's a lozenge pine cone. That's funny. That's funny, bro. It can be scraped off. Whoa, Canada can be scraped off. Not this one. That is so cool. Oh, that's nice. Nice, dude. That's nice. They very nice. Wow. This is a once-in-a-lifetime moment. Once-in-a-lifetime opportunity. It really do be like that, you know. Sometimes it really do be like one of our favorite things. Esophageal AIDS is like chief complaint CD4. Often occurs with other conditions. Treatment. Hey, no. Canada esophagitis and AIDS. The chief complaint is obviously going to be odynophagia, bro. We got some CD4 less than 100. We got oral thrush often occurs with what other condition? Oral thrush treatments. Empiric fluconazole. Empiric, we got some odynophagia. It do be like that. It's one of the best things in the universe. The universe has... Okay, I'm going off the crazy. Dysphagia. Okay, less than 100. Endoscopy findings. What are you looking at? A vesicular volcano-like. No one's going to say volcano. Come on. It's not a volcano. It's vesicular. It's not a volcano. It's not a volcano. Okay. Oral and esophageal conditions which can be seen in AIDS. What? Excuse me. Have I not discussed that? Oral candidiasis, oral leukoplakia, esophagus like CMV, HSV. What's the other one? I totally forgot. Canada, yeah, that's it. I won, dude. CMV, that's it's like super important. Less than 50. Odynophagia, and like you have these like erosions. You have like longitudinal erosions going downwards, bro, downwards. What is empiric treatment for a patient with HIV present with odynophagia? Flus. Give those fluconazole. Give the flucones. Yeah, give the flucones. I love the flucones. I do love the flucones. Name two ocular conditions that can be seen in AIDS. I do like some HSV retinitis. Keratitis, CMV, retinitis. I do love it. I do like it. What am I going to say? Presents with a painful ocular symptom, CMV retinitis. I don't know, bro. I don't know. It do be like that, but it's not exactly all that way. 6 reviews of system questions should be asked to evolve ocular conditions. So what are we looking at? Floaters, flashing lights, decreased vision, blurriness, discharge, and everyone's favorite, pain. 4 for esophagus. Okay, so white patches, obviously that makes sense. Sore throat, hoarseness, dysphagia. So whoa, this is the review system for this. We got some throat, we got lung, we got, I don't know what the hell that is. CMV retinitis, CD4, CMV is like less than 50. Did we just talk about it? It's kind of painless. It's like, yo, I can take it. Like, if you like, I actually thought it was painful, actually. Apparently it's painless. Controversial, okay. Unilateral or bilateral is unilateral. Fundoscopic findings. Retinal hemorrhages and fluffy white yellow lesions. You can't beat me. You just can't. Ocular symptoms. Fluffy white lesions. Floaters, painless, okay. And then HSV retinitis, CD4. It's less than 100. It's painful or painless. It's painful. Water discharge and pain, blurry vision. Unilateral findings with fluorescein drops. Dendritic lesions or geographic ulcers. Pale peripheral lesions and central necrosis. Fundoscopic is peripheral lesions and central necrosis. There's geographic ulcers on the cornea and HSV keratitis. With caries, ocular dwarf, okay, and unilateral ocular symptoms. An opportunistic infection in AIDS with CD4-200 is pulmonary. So you have PJP. What else? You got TB. You got everyone's favorite pneumonia. Everyone loves pneumonia. Everyone loves pneumonia. It's opportunistic infections in AIDS. HSV retinitis, keratitis, CMV retinitis. What is this? Painful. HSV is painful? Well, saying CMV is like painless. Okay, yeah. You know what? Fine. Esophagitis. We just talked about CMV. We talked about HSV. We talked about Canada. Let's get out of here. What are the common AIDS-associated illness in the U.S. and Africa? PJP in the U.S. and Africa TB. It's gonna be like that in India too. So, organisms that cause pulmonary infections: AIDS, fungal, bacterial, viral. Do we care? Actually, we didn't talk about this. No, we didn't. We didn't say fungus that much. We knew pneumocystis. Actually, that's not really. I don't know. Is pneumocystis really that? It really don't be like that sometimes. It doesn't look like. It doesn't feel that way. But we're just talking pulmonary. But then again, pneumocystis does have like a pulmonary. It does spread through respiratory secretions. You know what? Whatever, doesn't matter. Histoplasma cocci, invasive pulmonary aspergillosis, cryptococcosis. So chief complaint, most pulmonary opportunity infections in AIDS. It's usually they'll be like a dry. That is the word. Usually an infection should have some cough. AIDS is just dry. You're telling me AIDS is dry. That's kind of weird. That is kind of weird. Oh, okay. So GI. Oh, sorry. I kind of went out of track. You can't go out of track. You just cannot. Cryptosporidias and microsporidias. What is CD4? That's Christo. This is a weird one. How do you remember cystoisosporidiosis? That is the crypt. That's the micro, and that is the cysto. This is the weirdest one. Why did we decide to do this? I don't know. Multi-organ disease. You have a dragon, dude. You have a dragon. This is some Game of Thrones stuff. Actually, I don't think they can. They can't do Breaking Bad. They can't do Game of Thrones. They can go with like PG stuff. Cryptocystoisosporidiosis. CMV colitis, the disseminated MAC. Name to malignancies associated with AIDS that can affect GI tract. Lymphoma, Kaposi sarcoma. Yes, they can. Name to medication-related cause of diarrhea in AIDS patients. ART and C. diff. What? C. diff is the most random thing you can mention. C. diff. Well, that was Clostridium difficile. What even wasn't that? I don't remember. Okay. AIDS cholangiopathy. Causal organisms. There's so many. Cryptosporidiosis, CMV. Come on, we know this. No, I don't. I don't really know. It's like similar like to cysto. What are we looking at? Alkaline phosphatase. So it's like a cholestatic pattern. Just remember cholestatic pattern. Or what organism causes disseminated multi-organ disease in AIDS and presents with a high fever? You got some night sweats. You got some weight loss. Maybe some pain. Why do they hepatitis? What? What organ causes this? An organism that causes all this? The MAC, Mycobacterium avium complex. Wow, that hurts. That hurts. Okay, what age-related GI infection can cause explosive watery? It's only watery, but then you have hematochezia as well. Okay, thanks for giving it out. You know that was super helpful. Bowel perforation, toxic megacolon, abdominal pain. You know that was super helpful. What did you give me? CMV colitis. That was way better than the other stuff. CMV colitis, 2 age-related GI conditions that can be transmitted by contaminated water. Crypto and cysto. Everyone's favorite. Crypto and cysto. MAC and AIDS. The organs affected. We have liver. We have spleen. We have bone marrow. Like, can you see that? Actually, you can. No, you can't. But where is your bone marrow? Nowhere. Never mind. Okay. It was good. It was good knowing. It was good to know. Good to know. Really, chalk. We got chalk. We got some chalk markings, dude. You painted on a dragon. How dare you? How dare you? You know what, dude? That was kind of mean. That was kind of unnecessary. You painted on a dragon. CMV colitis and AIDS. What does it present with? I don't know. Abdominal pain. I kind of noticed. You should notice. Melena, watery diarrhea, explosive. It just explodes. Boom. Abdominal pain. Complications, toxic, and everyone's favorite. We can read this in CMV. I don't remember toxic megacolon. I don't remember bowel. I don't remember. Do I remember diarrhea? I don't think I remember. I don't think I did. I don't think I did. CMV colitis was such a weird one. Yeah, but you kind of okay. I can see hematochezia. Where's the oh? You do see bowel perforation, and also remember toxin colon, histocryptosporidiosis, and AIDS. How does it present with? CD4 count, risk factors. So obviously, presentations you're gonna have severe water diarrhea. You're gonna have some CD4 counts. You're gonna have some risk factors: contaminated water or animal contact. Severe watery diarrhea, also nausea, low pain, fever. CD4 is like less than 100. Contaminated water or animal contact. Yeah, I don't know. I don't know how, bro. I don't know, but we're just gonna have to go with it. Because like really just throw ourselves out there. Really just throw ourselves out there. Name drill stool diarrhea. Stool culture, rodent culture done for C. diff, ovum parasites. You know what? I am kind of bored with AIDS. I am bored with this topic. But there's still 150 left. Like, there's still 150. Okay, so GI conditions, labs, AST, stool, blood, endoscopy. Move on. Common renal conditions in advanced states, pathogenesis. HIV-associated nephropathy, that's why HIVAN, direct infection of glomerular and tubular epithelial cells. HIV-associated nephropathy population is African descent. It is like that. CD4 count is less than 200. Proteinuria, hematuria. Vital sign is hypertension. What do we have? We have less than 200. We have proteinuria. We have hematuria, hypertension, and edema. We have kidney biopsy for definitive diagnosis of HIV-AN. FSGS, edema. Yeah, I don't know what else. FSGS, edema, hypertension, proteinuria, hematuria. That's standard African descent. CD4 less than 200, less than 100, less than anogenital. Canada, bacterial, and HPV less than 100. What do we see? I don't even remember. This is going in. So, chancroid syphilis. Well, good luck with that. Good luck with that answer, bro, because you're not going to get anywhere. You're not going to get anywhere with that answer. What common HIV-associated gynae problems related with vaginal pruritus? So you have burning, soreness, dysuria, dyspareunia. You have vulvovaginal candidiasis. Okay, and you have, I don't know what else you have. That's just it. Odorous, it's kind of less than 200. Cool. Genital herpes and AIDS. Chief complaint CD4 count with workup. It's kind of painful. It's kind of less than 100, and you just go with HSV. Just go with HSV, HPV infection. Post coital. You have less than 200. You have anal and cervical. You have HPV 16 and 18. So what are we looking at? 16 and whatever. Okay, cool. Workup, intergenital complications in AIDS. We do that. I do that like. And so you have sample dishes for pH and microscopy. You have STI testing. You have biopsy suspicious lesions. Well, there's biopsy. We see the sample thing. We gotta discharge that. Neurological conditions associated with AIDS. See 200, 150. Excuse me, burping, dude. Excuse me. Just HIV-associated dementia. PML, plasma encephalitis, cryptococcal meningoencephalitis, primary CNS lymphoma, CMV encephalitis. Let me see this. Let me go through this. Dementia, progressive multifocal leukoencephalopathy. You got some ataxia stuff. You have toxic encephalitis, cryptococcal meningoencephalitis, Krabs, helmet with Epstein's, Brew, CNS lymphoma, CMV encephalitis. HIV, so dementia, is impaired motor function, neurocognitive deficits. CD4 less than 200. Toxoplasma encephalitis. Chief complaints CD4 is AMS, fever. Am I sounding boring? I sound bored. I sound really bored. Maybe we should spice things up, dude. I think we should maybe stop. Nah, I can't stop. 140 is a lot. 140 is way too much. It feels... Actually, you know what? I feel like I can go with it. I can kind of go through it. I don't know if you're going to like it. I don't know if you're going to like it. Maybe you might not like it. Cryptococcal meningoencephalitis, there's meningitis, encephalitis, CD4. Whatever. This is also with one infection. Yeah. How many of these questions are going to keep asking us? Sinus lymphoma, chief complaints. What could it be? Oh my god. Oh my god, dude. You have neurological issues? That's insane. You have what? Oh wow. I've never heard of that. PML and AIDS. What do you have? Another one? That's insane. Actually, this I should have known. Come on. Sinus condition AIDS. Did we not notice? What? Dude neuro. What is this weird ass dude? Hovering above. General MRI findings. Actually, this I don't think I saw. I didn't see this. But then again, there's nothing much. Enhancement, mass. You have some mass, and you have some enhancement. Enhancement of the mass. There's a mass effect and there's localized enhancement. It's important to mention that. MRI finds toxic encephalitis. What are you looking at? Ring enhancing. You got some rings. And you have a mass effect. It's important to mention that. Sinus lymphoma, we have periventricular lesion. Looks like a ventricle in my... Oh, you do have it mentioned here. Ring enhancing, and you have mass effect again. CMV encephalitis. Whoa, scattered? It's sort of scattered. Scattered across the web for enlarged ventricles with periventricular enhancement. Diffuse scattered micronodules, bro. I be the king. CMV encephalitis. You can't go against this guy. This guy just wins. And if in my way, it's like, I think I just went off track. I'm sorry. I gotta come back. MRI findings, HIV-associated dementia. Oh no, never mind. Enlarged ventricles and some atrophy. A basal ganglia white matter. So, whoa. Okay. PML. We're not remembering this. Who's gonna remember hypodense? Is that mentioned? Yeah, hypodense, fine, okay. Periventricular area subcortical, that's not mentioned. Well, only hypodense. Diagnosis of cryptococcal meningitis. CSF, we have CSF findings, confirmatory test. We have the India ink test. We should have mentioned it. We should have. And then encapsulated yeast. And then CR. What's CR? Oh, that's it. Okay. Yeah, they don't mention this in the micro. Maybe they did. And actually, no, they didn't. All right, so. Cryptococcal opening pressure is obviously going to be more. Like what? Glucose? I don't remember. What? Glucose? Who remembers glucose? No one. Okay. Culture? Yes. What? Okay. It says increase for fungal. This is kind of weird. What is this note saying? Sketch indicates that WBC count is less. First it says it's more for fungal meningitis. Who do we trust? The basics? Or what would be the opposite of your base? You know what? I am somewhat bad when it comes to vocab. What's the word? So if you have your base, sort of the traditional, what is this? The radicals? You're radical. That's a bad word. We should not use that. If you have your base and you have the challenger, the revolutionary. No, why am I here? Let's just move on. Workup for sinus lesion in AIDS. MRI LP brain biopsy. Okay, can we finally move on now? Can we finally move on? No, we need more. AIDS is a big topic. CMVT, I am tired of this. Brain biopsy findings of demyelination, bizarre astrocytes, and large oligodendronuclei are indicative of what condition? So, we have your favorite PML. I love a PML. Lab test for diagnosis of toxoplasma encephalitis is your serum toxo cat. Come on. Kaposi sarcoma. What is this? Molluscum contagiosum. CD4. I'm totally bored. I just cannot. Keep moving. Oh, it's a totally different. Kaposi sarcoma is your monster. And you have the molluscum. Oh wow, so you have some new stuff. Bacillary, that's in 50s. And you have genital herpes. The difference between this Henseley and Quintana? Thanks, bro. Henseley is your cat. Your lice is Quintana. Quintana is a lice, bro. Describe the skin lesions in the bacillary angiomatosis. Oh my god, bro. You think they're gonna care? It's not even mentioned that well. Red, purple, surface texture. They don't. You think they care? Grouping number, solitary, multiple. It's not mentioned in the sketch. Why does it matter? Like, it's not even that big of a deal. Like, come on. Can we not? 120 questions left. It's 5 o'clock. When did they start? How long have I been recording? How long has this been going on for? I don't know. Where's it mentioned? How long it started? Where's that mentioned? How long I've started? Can I just search myself? Let me just search myself. I don't know how. Let's just search myself. Okay. Let's just go to YouTube. Okay, I'm still here, but how long have I been doing this? Can I just search myself? Let me just search myself. I don't know how. Let's just search myself. Okay, let's just go to YouTube. Okay, I'm still here, but how long have I been doing this? Can I just search myself? Let me just search myself. I don't know how. Let's just search myself. Okay, let's just go to YouTube. Okay. Alrighty, guys. Alrighty. So, let's come back. Let's come back to the beautiful, painless. I am getting bored. I am already bored. Dude, that is insane. That's a world record. That is a world record, dude. That really is